So the main part of the criteria to look at is that this is occurring for multiple months at a time, right? So it's long-standing or chronic, and it's not something that life circumstances changes things for us, right? It's something that's very long-standing, and it is something that we have to see to make that diagnosis prior to age 12.
Welcome to Thriving with ADHD, a podcast where we'll share everyday practical tips to thrive in life as an adult with ADHD. This podcast is brought to you by Animo Sano Psychiatry, a behavioral health practice with a specialist ADHD clinic based in North Carolina. And this is your host, Nada Pupovac. Hello everyone and welcome back to Thriving with ADHD. I'm really glad you're here for this February episode because today we are going back to basics, talking about ADHD in a clear, grounded way that's helpful whether you are newly diagnosed, supporting someone with ADHD, or just looking to better understand how this condition actually works. Joining me today is Whitney Kost, physician assistant at Animo Sano Psychiatry. Whitney works closely with patients navigating ADHD and other mental health challenges, and she brings both clinical expertise and a very practical, compassionate perspective to this conversation. In today's episode, we'll cover what ADHD really is, how it's diagnosed, different types, how it shows up in everyday life, what's happening in the ADHD brain, treatment options, and so much more. So let's get started. Whitney, welcome to Thriving with ADHD. I am so happy to have you here. This is your first episode, so I'm really looking forward to get to know you better, our audience to get to know you better, and to expand on this conversation. And our goal today and for this episode is simple. Going back to the ADHD basics. We want to gain clarity, we want to gain understanding, and hopefully give a bit of reassurance for people. Maybe someone is just discovering that they have ADHD. Maybe they're well into this game. They know the rules, but they want some refresher, or we're here with family, friends, curious about finding out. So we are here to give a bit of a reassurance along the way in this conversation. So once again, the warmest welcome.
Thank you so much. I'm really excited to be chatting with you. Like we talked about, it's been a long time coming, so it feels really sweet to finally have the time to chat and things, and I'm excited to get into it.
Let's do it.
Okay.
So let's start by the very basic and first question. This is diagnostic criteria for ADHD. So can you share some of them with us?
Absolutely. Yeah. So I think a lot of people have a pretty good general understanding of what ADHD, or may even have suspicions, right? But I think really defining clinically what we're looking for and how we diagnose it is the most important thing. So not what we're reading online, not the rumors we hear from a friend and things like that. And a lot of those things can be true, but I think it's important to know, the true definition of it. So it is a neurodevelopmental disorder, and the main criteria really comes in parts, I would say. So clinically, we look at certain things like difficulty with following instructions, maybe difficulty starting tasks, completing tasks, things along those lines. We may even see restlessness, fidgeting, interrupting, all of those things, just to name a few. But really what I try to emphasize and talk to patients about that I don't think people recognize is a lot of us can struggle with those things day to day, but that doesn't mean we have ADHD. Sometimes it can, but sometimes not. So the main part of the criteria to look at is that this is occurring for multiple months at a time, right? So it's long-standing or chronic, as we say. And it's not something that, life circumstances changes things for us, right? So maybe we've lost a loved one, and then, we have difficulty paying attention in school, months following and things like that. It's something that's very long standing, and it is something that we see and have to see to make that diagnosis prior to age 12. So it starts pretty early on in life. And it has to be something that impacts multiple facets of our life. So it's not just at school. We hate going to school. We really don't like it. Class is
Yes,
boring,
okay.
all those things. It's impacting school, home, work, social settings, whatever it may be. So multiple areas, and it has to interfere and reduce the quality of those functionings in those settings. So it's something that is across the board happening in every avenue of our lives.
Thank you for
Yeah,
emphasizing. And I personally, I wonder, oh, do I have ADHD? I recognize the symptoms in myself, and I would be lying if I said, yeah, well, that never crossed my mind. But what you're saying right now is just busting some of the misconceptions that I personally had.
sure.
And I'm sure people listening to this. So this is such an important conversation. So, okay, then let's talk about, uh, from clinical perspective, what's happening in ADHD brain?
Yeah, that's
Mm,
a great question. And, it's something that I think we're all still learning, all trying to get a better understanding of. The brain is a very interesting
mm,
area of our bodies that is quite complex, but we're focused primarily on the prefrontal cortex area. And when we say prefrontal cortex, I want you to think about things like planning. Um,
mm.
Organizing, time management, task organization. So when we have multiple things to do, how are we organizing those tasks? How do we rank them? How do we prioritize them? So that's really the area of the brain that tends to be affected with ADHD. Um, I would say that it's pretty well accepted that folks who have ADHD typically have decreased neurotransmitters in this area of the brain. So the specific neurotransmitters that we see decreased are dopamine and norepinephrine. Dopamine, I want you to think about reward and motivation. So when we have a depletion of these neurotransmitters, we can see how that might affect, the organization that we need to do or the task ranking that we need to do.
Thank you for explaining that.
Yeah.
And um, my next question would be, I'm sure folks out there heard ADD and then ADHD. And are these the same things or is it different? So can you just explain this to
Yeah.
us? Yeah.
That's a good question as well. And it's one that I commonly see patients, write that that's what they're interested in discussing, that they think that they have ADD and things. And it's nothing I would expect patients or people to know necessarily, but to educate ourselves and kind of better know. ADD is actually a dated term now. So we really only
Mhm.
reference it as ADHD.
Okay.
So ADD was a term, so it's not inappropriate or wrong, but it's just not as accurate or up to date, if you will. So
Okay.
it's actually removed with the new release of the DSM-4. So
Mm.
the DSM, you're kind of may or may not know what it is what we clinically, and I kind of laugh saying this, and I think my fellow colleagues will probably too, is kind of our Bible or our
Bible. Okay. Yes,
point,
yes, yes.
right? So it's a tool we use and it lists diagnostic criteria for psychiatric
Mm.
disorders.
Okay.
So the main important thing to note about the DSM-5 is it doesn't just list the criteria, but also the pattern of behaviors to meet the diagnostic criteria of whatever disorders. So in this instance, ADHD is in there as well. It's put
Okay.
out by the American Psychiatric Association.
Mm.
Um, so with the release of the DSM-4 was when ADD was removed. The most current up-to-date version of the DSM is the DSM-5, and that was put out a few years ago now,
Mhm.
2022.
Okay.
And that actually recognizes three different types of ADHD.
Okay. Yes, and then we were talking about the types in the past in the episodes, but can we refresh our memories and explain which types we do have?
Yeah, yeah.
Hmm.
So I think this is really interesting about ADHD, and it
Hmm.
kind of, makes it a little bit more challenging to maybe spot when we are younger and things like that, which I know we've talked about before
Yes.
and stuff like that. But there are three subtypes. So there's inattentive, hyperactive, and impulsive. Those are grouped together. And then we can have combined typed or a combination of the two.
To make things interesting.
Yes,
Yeah.
exactly, exactly.
And would you mind describing just shortly each type?
Yeah, so with inattentive type was some of the things that we touched on a little bit earlier. So
Mm-hmm.
that might be the difficulty with starting and finishing tasks.
Mm.
Maybe we make careless mistakes, have poor attention to detail. We may be getting easily distracted by things. We might even find that we're forgetful in daily
Yeah.
activities. So that's something that I commonly hear patients say is I feel like I have a really poor memory, right? And
Mm.
naturally, as we age, our memory does decline. So that's something to consider. But it could be that, while we're trying to almost intake all of the information, we're not storing it. And so we're not able to then recall what had occurred earlier. And
Mm.
that appears as forgetfulness.
Mm.
So that would be inattentive type. Hyperactive and or impulsive type is also kind of self-explanatory, but
Mm.
people might be described as always being on the go, or something I commonly talk to my patients about is, again, going back to the multiple facets that it impacts in our life, right? So we're getting in trouble at school for interrupting the teacher, but we also get in trouble for interrupting our parents at the dinner table. So
Uh-huh.
it's showing up in multiple areas. So we see talkativeness, difficulty waiting our turn, a lot of restlessness, fidgeting, getting up out of our seat. And then combined is, of course, when we meet enough criteria. So it's actually meeting a certain amount of criteria in both of those categories to
Mm.
meet the combined diagnosis.
Yeah. 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 Thanks for explaining that. So then we also know that there is an overlap of
Mhm.
ADHD with other psychiatric disorders, which makes it a bit challenging, I suppose, to diagnose each. So would you mind explaining which conditions are most commonly overlapping with ADHD and what maybe people should be looking out for?
Yeah, I
Yeah.
think what's important to note is because there is overlap, it can be difficult to, as you said, diagnose, but that
Yeah.
doesn't mean that they're exclusive, right? So we can have anxiety, we can have depression, and we can have ADHD.
Mm.
Now, sometimes that's not the case, it really just depends on the individual and what they're experiencing and maybe struggling with.
Mm.
But it can be that we have all of those conditions and other conditions, even, mood disorders, even just an attention deficit that doesn't quite meet the criteria of ADHD as well. So I would say something that I commonly try to define, and I think a lot of my colleagues do as well, is like we touched on, there's an impulsive behavior that can come sometimes with ADHD.
Okay.
And so, really trying to define where this impulsive behavior comes from, the severity of it, and taking a look at what specifically the impulsive behaviors may be. So, like we said with ADHD, it's going to show as restlessness, fidgeting, getting up out of our seat, interrupting, all those things that we touched on.
Mm-hmm. Mm-hmm.
But we can also see it in mood disorders. So, being impulsive in the way of maybe spending sprees, making careless decisions, having some reckless behaviors like speeding, even things like that, can overlap in terms of the impulsive behaviors that we see.
Mm-hmm.
And that can point more towards an elevated or energetic behavior, right? So,
Yeah.
even crossing into manic behavior. So
Okay.
it's really important to kind of separate those and see what a patient's experiencing.
Oh, that's very interesting. And it's a challenge, but not impossible. And perhaps
Mhm.
that's why important to seek professional help and together with physician assistant, with therapists to discern what's really going on. Because I think then the outcomes of the treatment would be better. Correct?
Yeah,
Yeah,
absolutely.
yeah.
I think, if we can get answers, and I say this
Mhm.
to my patients all the time,
Yes.
so if any of them are listening, they're going to be like, wow, we've had this exact conversation. So I apologize. But, I think just the goal remains the same for, patients is functioning, right? How are we
Mm,
functioning? How can we improve our quality of life?
mm.
A diagnosis doesn't necessarily define who you are. And so are we functioning? Have we improved our quality of life? And that's kind of our North Star.
Okay.
So if we can diagnose someone and get them answers, that's great and kind of gives us a direction to head in and, of course, treatment to follow.
Exactly. Exactly.
Mhm.
So not the goal is not labels, but direction
Yeah,
towards
exactly.
better quality of life. That's I love it.
Yes.
I love it. Excellent. Excellent. So yeah, speaking of quality of life, let's
hmm
talk about some common struggles of patients with ADHD. When you said it's not just a few symptoms here or there, it's a condition that is impacting everyday life for months, probably for years for some people. So how does that look? Yeah.
Yeah, I would say one of the most common things that I see in clinical practice or common things that patients report to me rather is motivation, right? That's something that I
Mm,
just hear over and over again. And also, again, if my colleagues are listening, they'll probably be aligned with me on that too. And
mm,
similar to impulsive behaviors, motivation can be a difficult thing to sort through as well. So we see a decline in motivation with, even conditions like depression. And so in that case, right, we can label it more clearly and define it more clearly from an anhedonic standpoint or experiencing anhedonia, right? Defining that word as lack of interest and lack of pleasure or enjoyment of things that we used to enjoy. So one thing I always say to patients is, it's not necessarily well, now I don't enjoy emptying the dishwasher or doing certain chores, right? It's our hobbies and things that kind of make us us and define us us.
mm.
But I would say that's something that is commonly seen as we talked about. ADHD affects motivation in the way of dopamine. And so people with ADHD also struggle with motivation. And so, again, sorting through the weeds of what is causing what and could it be both, even, is a fair question.
Yeah.
Um, so I definitely see that overlap in general with, depressed patients, but also other conditions. I think the important thing and what helps us sort through the weeds would be, uh, ADHD, it says over and over again in the DSM-5 that it's not just oppositional behavior. So really that, we're not deciding to not do these things, right? Or we're kind of almost being stubborn in a way. It's important to note that we're truly lacking that motivation, kind of that increase in energy to be able to do them, or maybe the focus to be able to do them long enough, if you will. Again, going back to the DSM-5, the main tool that we use, it also says very clearly that it cannot be attributed or better explained by another psychiatric disorder. So again, the overlap comes back, right? We talked about a mood disorder. We've talked about, depression, even anxiety. And so that's why it's so critical to kind of get our arms around and treat the anxiety, treat the depression, improve our sleep, limit substance use, all of those things so that we can say, okay, now that these things are stable, this is true ADHD. We're still having these issues, if you will.
Oh, excellent. And I think this is an excellent introduction to my next question. So I think
Mhm.
you kind of touched on with answering the previous one, but some of the biggest myths around ADHD that you wish would just disappear. I know it's not possible, but we can dream on, and hopefully, with
Yeah,
each and every conversation like this one, we can kind of help to change the narrative. So, what are some of
yeah.
the things that you would definitely like to see changed?
And help educate, right? That's really
Exactly,
what it is.
exactly, exactly.
We don't know what we
That's
don't
it.
know, and so
That's
now
it.
we know, and we can have these conversations, which is great.
Yes,
I think what I had touched on before, I think it's important to speak of it appropriately, right? So
yes.
changing from ADD to ADHD and then listing the subtypes. So, ADHD-I or inattentive type, if you will. So speaking about the condition, appropriately and up to date. But then also I would say a thing that I read on the internet and are on online forums and things like that would be adult onset ADHD.
Uh-huh.
And again, I don't fault a patient maybe for not knowing this or just not having the exposure to these conversations. And I think that's the beauty of coming to meet with us and getting to hash out these details. But I also think if you're in pursuit of being diagnosed with something, and slash or if you are going to be diagnosed with something, you should know this about a condition that you may struggle with or may have.
Mm.
So ADHD is not something that is adult onset. As we talked about the criteria earlier, it has to be present prior to age 12. It very clearly says that in the criteria. So when interviewing patients, I think it's really important to have conversations about what elementary school looked like, what middle school looked like, some of those years, and what concerns teachers may or may not have had, what parents said, what our backpack looked like, but also what our room looked like, and all of those things going to that. So the patients who are diagnosed later on in life, right? So there are people who are diagnosed as adults, and that's something that I think is important to establish were just not diagnosed when they were younger. So it was a misdiagnosis. We commonly, of course, I know you talked about this in previous episodes, but we do
Mm.
see that more commonly in our females, right? So
Yes.
there's a higher percentage of females that have ADHD inattentive type. And so we
Yes.
may miss the diagnosis before age 12 or even a few years following because they're not up out of their seat and moving around and fidgeting and things like that. Now, gender aside, that can happen on both sides, right? But that's just an
Okay.
example of how it can be missed. They sit attentively, and there's no concerns as far as grades and things along those lines. And I think that too is an important piece to distinguish that ADHD does not equal or impact intelligence, right? So it's a neurodevelopmental disorder, but it's not something that means we're automatically not going to get the grades that we would like, or we can't be high achieving and things like that. So those two
Mm.
things do not equate each other. I would say when patients are diagnosed later on in life, they've often learned certain behaviors to compensate or overcome. We use a terminology called masking.
Mm.
And so it's basically, as it sounds, there's a demand, and that demand continues to increase. And so we learn skills to overcome those demands. When
Yes.
patients present later on in life, it tends to be that these skills that they've either self-taught or have been exemplified for them are no longer holding them. They're no longer able to function. The demands have gotten so much higher. So it's not uncommon to see patients who, have done well all their life in school, and then suddenly they get to a higher level of learning, such as grad school or maybe getting a PhD. I feel like that's something I commonly see in
Mm.
clinic. And suddenly everything's moving too fast. They can't keep up, and that's when they really notice some of these symptoms. So that's where we can see patients diagnosed way later than 12 years old even.
All right. Very interesting. Very interesting. So thank you so much. I was listening and my mouth was like wide open and gapping. I was okay, okay, okay.
Yes.
So
Yeah.
thank you. Thank you for that. This is, I mean, golden. Everything you said. Thank you so much for sharing that. So
Yeah.
let's talk about treatment options. Let's talk
Mhm.
about medication, therapy. You touched on some lifestyle changes. So once you have the symptoms under control with the medication and stuff like that, you do need to learn some of the life skills to help yourself. So,
Mhm.
and yes, I think as a practice, we are promoting kind of comprehensive care, not just medication, but
Absolutely.
to care about the patients as a whole person. So, what would you suggest? What would be the way to go?
Yeah, that's a great question. And I know some of this has touched on in other episodes as well, but I think it's great to revisit and
Absolutely,
um,
100%.
kind
Yes.
of have a clear point of next steps, right? So now what? I've been diagnosed. Now what? What does that
Yes,
mean?
exactly,
Um,
exactly.
and so stimulants or a class of medication is the known first line treatment for ADHD.
Okay.
We tend to see a pretty robust response with stimulants. They're effective medications. We can see a lot of remission of symptoms of ADHD with these medications, and they're largely impactful.
Mm,
Patients who come to me and haven't been diagnosed, we assign the diagnosis, they meet the criteria, all those good things, and then we initiate a stimulant, and they're largely responsive to it. They do very well with it, and some even make the remarks of, "Oh, this is the best I've felt in my entire life," and things like that.
excellent. Excellent.
They do hold a great response, which is encouraging. So, we can see improvement in quality of life. Stimulants specifically, how do they work? Typically affect those neurotransmitters that we talked about earlier. So they affect dopamine and norepinephrine. So they really work on the motivation pathways and the reward systems that we're considering. There's additional options. So there's also non-stimulants. That's another class of medications that also have approval for ADHD that are also effective. The difference, I would say, is they're technically not first line, but everyone looking at it case by case has different requirements, right? Some we need to monitor blood pressure, or some have side effects that or polypharmacy, mixing medications with other medications. So a lot of things to consider in that decision making. But I'd also say, just as we touched on before, that behavioral skills are so important. And like I mentioned, a lot of patients will come to me later on in life and be diagnosed, and they already have a lot of skills, which is great
Mm,
because they've had to have those skills, right? They've had to meet
yes.
those higher
To
demands.
survive.
Yes, exactly. And so that is really encouraging that we're pairing the medication with the behavioral skills. And that is where I see patients have the best response and improve the most. And I would also say, the support from therapy is huge. And so if we don't have those behavioral skills, if, maybe we haven't learned them, or maybe we are younger, therapy is a great option to help build those skills, learn them. What do they look like? Some examples, setting alarms, keeping lists, body doubling, so doing things with friends, all of those things can help improve our functioning. And
Mm.
also paired with medication, you're golden.
Excellent. Excellent. Thank you so
Yeah.
much.
Yeah.
So let's wrap it up. And you, this was excellent. I learned so much from you. Thank you.
Yeah.
So, if there is one thing, one takeaway that you would like our listeners to take away from everything you said so far, what that would be?
Yeah. Well, actually, Nada, I want to mention before we do move on that
Yes.
something that I've learned, I'd say within the last maybe 2 years of my clinical practice, that there's even beyond therapy, there's ADHD coaching now available too.
Yes,
So
yes, I saw that. Yeah,
I
yeah,
know sometimes that patients can have their own relationship with therapy, right?
yeah.
Sometimes based off of past experiences or kind of perspectives they may have on it. And
Mm,
ADHD coaching can be really valuable to just focus on building those skills as well, and
excellent.
really
Yeah.
diving into those specific tools. But great question in terms of kind of the big takeaway, and it's a
Mhm.
difficult thing to summarize
I know that. Yeah, yeah, you're right.
and kind of group together. But I would say, I want to encourage patients, like I said, that, it's just a diagnosis. So it helps gets us answers, and it gets us closer to you having a better quality of life, but it doesn't, change who you are. You're still the same person, and hopefully just a little bit of a better version of yourself, and you still remain who you are. I also think that it's important to consider, like we touched on, it's an exclusive thing to be diagnosed, right? So we know anxiety is well controlled. We know mood is well controlled. We don't struggle with depression. We've never struggled with depression, or we don't use any type of substances and things like that. And so then we can confidently say this is ADHD. So I would say if patients are listening and willing to hear this, taking into account some of those things and being honest with yourself, I really only get 5 or 6 hours of sleep a night. And can we improve our sleep hygiene so that our cognitive function and things are improved overall? I would say one thing people commonly overlook is, cannabis use, even caffeine. So we know that marijuana or THC interacts with I think it's the endocannabinoid system. And so this actually system modulates dopamine, back to dopamine again, the reward and motivation piece of things. So if we're actively using cannabis, and with that, a lot of it, you can see how that would influence ADHD symptoms and things like that as well. Similarly, caffeine is a stimulant. And so taking into consideration how much caffeine we drink in a day and, what has caffeine in it, sometimes that surprises people as well. So I think it's important to summarize, it's big picture things. It's not just one thing, and being honest with yourself about some of the behaviors aside from attributing it to an ADHD diagnosis.
All right. Thank you, Whitney, for sharing all of this valuable information with us. And I'm really grateful. I hope we can have you back because, oh my God, you were spilling like truth after truth after truth. So, and I would definitely like more of that in this podcast. So we hope to have you back. True.
Thank you so much. I've enjoyed talking to you, and hopefully I'll get a chance to come back.
Thank you for listening to Thriving with ADHD. This show is produced by Animo Sano Psychiatry. Please follow, rate, or share our podcast on Spotify, Apple Podcasts, or any other streaming app of your choice. Music is by Daddy's Music from Pixabay. For more information about Animo Sano Psychiatry, please visit animosanopsychiatry.com.